kids. They don't complain because they have no voice. They're just adapting to a problem. Please tell me so, because they're a symptom.
Mm-hmm.
All the things that we treat in adults comes down to lips, tongue, and breathing. And what is the first thing we do when we're born? We breathe. He stopped snoring and he started hearing. Nothing to do with teeth. Compensation is the tax you pay when prevention fails.
Stefan, wonderful to have you on. As I was saying to you just before we started the chat, when I thought about Contact Point, your name was one of the first on the to get on list.
Thank you.
Because I think that when I look at the next 10 years in dentistry, yes, there's technology. Yes, there's AI. There's 3D printing. There's so much exciting stuff, many of which you're implementing in your practice. But conceptually, in this country especially, I think that the incorporation of Airway into all of our different treatment plans, or the awareness, at least as a starting point of it, is so important to the way that we look at things moving forward. And as you may well know, my wife, Dr. Megan, has been on her own journey with this in terms of learning about it and trying to spread the word about it. She views you as a celebrity in the space. I think that she's starstruck seeing you today. And I've obviously known of your work for many, many years, but I've seen more and more over the last couple of years that you're really front and center in this topic. And I think it's a very important one. I think it's a huge, if not one of the biggest opportunities that we have as clinicians, dentists, full stop, whether that be specialists or paediatric or dentist GPs. We can dive into that in a second, but it's great to have you here.
Thank you for having me. I mean, you touched on so many points already. I mean, look, first of all, I want to start the terminology airway. It's not about airway, because airway is the talking airway. We don't know. There's no evidence. Let's just talk about sleep disordered breathing.
Mm-hmm.
About breathing, not about air, because airway is multifactorial. We have a nose, we have a throat, we have oral cavity. Airway is very hard to grasp as a professional in our area. I'm an orthodontist, you're a dentist, we look at teeth, we look at oral cavities. This is not airway. Airway is much more, it's ear, craniofacial complex, noses. So we need to talk about sleep disordered breathing. And then you touch base of, I'm a celebrity in this space right now. I don't know if I am. I'm very passionate about what I do. That's correct. And the whole thing started with this. Like, my basic training was conceptually about functional devices in orthodontics in Germany. I do this forever. Since my training, 2008, my boss when we took a bite to change the position of the lower jaw and cushion, we had an osteopath coming in, checking how the body responds to that bite, checking the leg discrepancy, checking the shoulder posture. And at the time, I thought that's the way it is because she's my boss. That's the way we are trained. And I just took it on. I didn't think a lot about it. But we looked at posture adaptation compared to the bite. So then I did my training, finished as a specialist, worked in Switzerland in children, did functional devices all day, every day. Frankel, Bionator, Activator. And then 10 years ago, I ended up in Harley Street. So you go to Harley Street, you think, okay, as an orthodontist, you treat children. You don't. Go to Harley Street, there are no children. You go there, you get thrown in this shark pond full of sharks. They all want a piece of the cake, and you treat adults. So then, how are you different with this? Everyone does Invisalign. God knows how many diamond users are on that road. So I did Lingual. I became very good in Lingual. Adults, I became a niche in that moment. I became a good number one in the world 2017. But then you realize when you treat adults, you know that you treat only problems, symptoms, fractures, abfractions, crowding, wear facets, sleep disorder, breathing, snoring, whatever. It's only symptomatic treatment. And you do your best job you can ever do, and you still have these odd patients saying, I'm not happy with this. I want a refund or whatever it is. It doesn't fulfill you with a lot of satisfaction. So then I started working for a kids company in London, and then lockdown happened. I said, okay, what do I do with my time now? So I started to read and podcasts and all of things. So I listened to all the speakers in the world. I said, okay, let's look into this aligner world, Invisalign. What is it? I never did a case of Invisalign in my life because I just fixed the cases that were failing with Lingual. So it wasn't need for me.
Mm-hmm.
So then I looked into Invisalign, and just before that, in the same year, I became a single dad of 3 children. So my life changed. So my focus was not actually my clinic anymore. My focus was my children, to get safeguarding to my children. And I met my wife, Dr. Komal Suri. She was a very well-known person, restorative dentist, COIS graduate in the UK, speaking all over the world about functional rehabilitation, bites, occlusion. So I met her in the same year, 2017, 18, and she said to me, I need you as my orthodontist, but have you ever seen your failures 30 years after you completed your orthodontics? I said, what do you mean? I said, no, I'm an orthodontist. I'm perfect. Number 1 in the world. I moved teeth into class 1. I said, yeah, you moved them into class 1, and at 30, you have wear facets, abfraction, and so on. I show you. I said, okay, you need to go to see John Coyce. That was 2019. I went to see him. I took money, even I didn't have a lot of money because I was going through legal stuff. So I went there, and then I realized the language a dentist is speaking is a completely different language to an orthodontist. We think about class 1 and how to do biomechanics to move them into class 1, because we are being told by angle, this is a stable bite. So, but now, if I would tell you, Angle, published in Dental Cosmos in 1899, class 1, 2, 3, but he also said the reason for class 2, div 1 is airway, mouth breathing. 1899, 125 years ago. So we forgot it, but I learned dentists look at functional stabilization, wear facets, deprogramming bites. I had no clue. But I'm dealing with full mouth rehabilitation every day, moving teeth. Mm-hmm. But I don't know anything about it. What a shame. So I learned dentistry, full mouth rehabilitation, even I never do it. But I had to understand I'm actually doing it by moving the teeth. Mm-hmm. So it enriched my horizon. So then what happened is 2022, lockdown happened. I did all the research with Invisalign. I thought, okay, a lot of speakers I knew from the Lingual world suddenly changing to Invisalign. Why? So it must work nowadays. So I looked into it, and the results I've seen was says, okay, that's good, acceptable. It's all about biomechanics. It's a different way of thinking. Yeah, when with a wire, you need to put a wire in, the wire moves. With the lines, you need to stage. Okay, you learn about biomechanics, all these staging protocols. Okay, you can do it. So I went back to that kids clinic in 2020. And I said, I'm not doing functional now anymore. I will do everything with aligners, because if you understand what you do with expanders before, you can do the same with an aligner in kids. And guess what? They love it. Mm-hmm. Wearing a bionator or an expander device, which is bulky, and an aligner is 2 different stories. Mm-hmm. And they suddenly loved it. They did a good wear time, and they're moving like honestly unbelievable. The feedback was great. So I was growing 700% in the first year doing ever Invisalign. And not on teenagers or adults, on kids. Mm-hmm. So, of course, Invisalign, Dr. My daughter says, who are you? What's that? We're the only one doing only kids. And you're growing like crazy. I said, yeah, because what do we need to do in kids? We expand, create a bigger foundation, and open spaces for teeth. Look at the research of aligners. The most predictable movements in aligners is expansion, opening space. Yeah. So, it might look like that's the best tool actually for early interceptive orthodontics, because the minute you have torque and whatever issues, it becomes unpredictable. Then I can do Lingual. Mm-hmm. So, but then going back to John Coy, so I looked at all of these pictures and the case they were discussing, wear facets. So at one point I said to John, you know, a lot of these cases you are saying they are tongue-tied. And their tongue is sitting low. That's why the upper arch collapsed. That's why the teeth incline. That's why they got a traumatic bite. That's why you have recession and wear. He looked at me and says, huh? What are you saying? What is a tongue tie? What has it to do with full mouth rehabilitation? I said, I tell you how. The tongue sits low, can't develop the upper jaw. The upper jaw collapse, you get into crossbite. They'll get function shifts, you get wear facets. He says, show me the research. So John is full evidence. So I sent him all the research. And then he said to me, I get emotional now. He said, 2022, Stefan, you need to speak on my symposium. I was a no-name. So I got invited 2022 to speak in a symposium for John Coyce in front of 600 top dentists of the world as a first-time attendee ever. Speaking in front of the stage, I was so nervous because I said, what does he want from me? I'm not evidence-based. I just be passionate about what I do. So I showed him the cases in kids, what I prevented the problem. And he was amazed. So he made me his clinical advisor for orthodontics and Airway. I said, wow, this is, I mean, from a restorative point of view, this is what's like you're getting the holy grail of dentistry. I'm an orthodontist. So that was for me being with my wife, who said to me, have you seen your cases failing? To then being connected to John Coyce gave me massive confidence boost. So I digged. I said, okay, let's look into this deeper. Kids, when does wear start? You have been told at university, kids grinding their teeth is normal, right? Mm-hmm. Don't worry about it. They will grow out of it. You have heard, oh, kids' teeth wear down. Don't worry about it. They fall out. No problem. You've been told the kids are crowded. The teeth are crowded. Wait and see. I said, actually, but when you look at the restorative side of things, I learned constricted envelope of function. We have a deep bite, they're touching in the front, they're shifting back, get TMJ pain, wear facets. Then I look at the 4-year-old kid, comes in with grinding. Same thing. They touch in the front, grind back, teeth wear down. They just don't have TMJ because they're kids. And they don't complain because they have no voice. They're just adapting to a problem. So then I realized with my friend Christian Leonhardt, we're giving the Coyce course in 4 weeks.
Christian will be coming on the podcast soon as well.
Yeah. So Christian and me, we met at the Coyce Symposium. John Coyce let me speak about kids and let him speak about adults. And then we realized we're speaking the same language. You do adults, the problems. I prevent the problem. This fits really well together. So we met. Christian is a genius, a nerd, whatever you want to call. He sleeps 3 hours a night. Yeah. So
we don't recommend that.
So we don't, but it's enough for him. And he stimulated my brain. And it's hard for me to get stimulation in my profession. He said, let's look into this. Let's look into this. So together we just got pushing each other. Let's look into the palate. So I said, okay, kids that stop breathing at night, they have a different palate. So I scanned all of my kids and said, look, these are the different palate shapes. So I sent it to Chris and look, the kids with sleep apnea, they have this, we call it now fjord-shaped palate. And I sent it to Chris and 2 days later, he said, Stefan, I made a lecture out of it. Bam! Designed everything. I said, we call it U-shape, V-shape, fjord shape. And the V and fjord shape are high-risk patients. Boom, lecture done.
Fjord shape.
Fjord, like a fjord. It looks like a fjord.
Right. What does a fjord look like for those that haven't seen one?
So they're very narrow in the palate, and then they go narrow up, and then they fjord out.
Right.
So long story short, the tongue doesn't fit in there.
Mm-hmm.
So the tongue has never seen that fjord because the tongue sits low. Mm-hmm. So coming back to the tongue. So with meeting Christian, we understood adults and kids are directly linked because if you don't see the problem early, you have the symptoms later. And you can say to adult, this was you as a kid. You can go back and forth. So now if a patient comes in, let's say they're 10, I can say, this is where you were as a 4-year-old. Well, I ask the questions, how did you sleep? How did you breastfeed? And then they get emotional. I said, hold on a minute. How does he know all this? I look at the palate. Mm-hmm. The palate tells me the story. The teeth tell me the story because they're a symptom. Mm-hmm. So I dig so deep that, like you, I do podcasts with people who connect the body with the mouth. And then you look at autism. There's so many things to discuss. But basically what it comes down to is when you look at airway and we look at problems in adults in airway and all the parameters you can measure in adults, which is very easy because you have structure that is set. You can look at SNA, VMA, whatever. There are data points, research, and we have the evidence. When this is less, we call it a high-risk airway patient. So, but now if you look at this high-risk adult airway patient and we decrease the age of that, so that's okay, which of these symptoms do appear in teenagers? TMJ, sometimes, rarely. Wear, yes, but not as much. Then you go further down in the age, 6 to 10, even less. Then you go eventually down to 0 to 3. And you realize, okay, what symptoms do kids from 0 to 3 have? There are only 3. Lips are not together, the tongue is not up, or the breathing is not through the mouth. 3 things called function.
The breathing is through the mouth. Yeah.
So the function is not correct. The lips are not sealed, the tongue is not up, and the nose is not engaged.
Mm-hmm.
So we realized that was 2 o'clock in the morning after a whole day of teaching. We did this product and we started crying. It says, oh my goodness, we just proven that all the things that we treat in adults comes down to lips, tongue, and breathing. So if a baby is born and it breathes through the nose, the tongue is sucked to the roof of the mouth, and the lips are shut, the likelihood they have ever airway issues is very low.
Mm-hmm.
But these things can change because sometimes we have viruses going around, then the adenoids, the tonsils are getting stimulated, they start to grow, obstructing airway. Mouth opens up. So you get in low tongue resting position. And then the tongue is not up anymore, so the palate starts to respond. And the longer you're going to wait, the more it's going to respond. Eventually you have a crossbite. So now, where are we in this country? We need an IOTN, Index of Orthodontic Treatment Necessity, which is a crossbite. So we have to wait for this to happen for us to have a valid indication to treat. But even then, the NHS doesn't pay you a lot of money for that. You get £100, £200. So it says, I have a contract to fulfill. So I get £1,200 for extracting teeth later. Maybe I should wait. Wait and see. What have you been told at university? Wait and see. Until all permanent dentition has erupted. Sounds familiar?
Mm-hmm.
But the guideline actually says is we should screen by age 7. Not from age 7, by age 7. And now the AAO just recently updated their white paper on airway. And they say we should screen kids by age 7, but we can treat them earlier if we see stuff.
This is the American Orthodontic
American also,
Association.
if we see stuff.
Stuff.
What does that mean? What does stuff mean?
Yeah.
And they also clarified, just updated paper a few weeks ago, we could play a role in screening for sleep disorder breathing in children. We could play a role. That's good.
Mm-hmm.
That means airway is maybe not so foreign
Crazy.
anymore. They actually accept we could play a role, and we do. We might not be able to diagnose sleep disorder breathing because we need professionals to do that. We might need a polysomnography, go in hospital, getting cabled up, do that on a kid, good luck. But we can play a role. Okay, what is that role? I can tell you. The role is for us, dentists, orthodontists, to assess the risk, looking at kids. We call it paediatric sleep disorder breathing. So Saru Sagi and Audrey Yoon, they published the Ferris 6 a few years back based on Christian Guilleminault, who developed the AHI. So Pharynx, they look at different things: tonsils, tongue restriction, narrow palates, yeah, a malampati, grinding. So I looked at that list and I said, but my kids who have struggles, they have more symptoms like this. They have retrognathic jaw profile, retrognathic upper jaw. So I built on that list and discovered 14 points. I screen every patient. So I basically have discovered my own list of 14 points I screen every kid. So I go through these points, and when I have a moderate to high risk patient, I know there's a problem. So then our role is to screen. Then we should refer to an ENT to check. So now let's talk about ENT in this country.
Difficult to get a referral, certainly on the NHS.
Correct. It takes ages to get a referral, and then a lot of times I hear from parents they didn't even look. They said, antibiotics, it's not bad enough. You don't have any problems. You don't stop enough breathing enough. Go away.
Yeah, my sister had a similar experience recently, actually.
Yeah. So now it's your sister that close to your heart. Yeah. And that is a different story. So ENTs, they don't look. Maybe time pressure, whatever the reason is. So now I have diagnostics. I have my screening. I have a high-risk patient. I have cephalometric data where I can clearly see the adenoids. I'm not allowed to diagnose obstruction, but I can see there's a structure behind the maxilla where there's not a lot of air in front of it. Here's the x-ray. There's my potential risk. Please check. So now they have to. And now what Smile Image gives us, data, a new technology, they have now a ring that is available for Smile Image. The first approved device for children, which is a ring you can put on the finger of a child at home. A home sleep test.
Okay.
For children. So now maybe very soon we can say we have a high-risk patient by my assessment from extra all features, and we're looking at the patient. Now I can say I can do a sleep test where I can get a diagnosis done by a professional. So I might get a diagnosis of sleep apnea in children or upper airway resistance. So maybe soon we can treat that, because what we also know from ENT world, this is a scary bit. When you look at evidence, if you always just look at orthodontic papers, you will always look research at how to move teeth into class 1 using different tools, aligners, whatever. It's boring. It's always the same. Or how to get an impacted canine down. But when you look at ENT papers or sleep medicine papers, there actually comes research like maxillary expansion plus myofunctional therapy can avoid the surgery. So you could eventually avoid removing tonsil adenoids by doing expansion and myofunctional therapy. So we're back to function. So when you see these ENTs, you talk to them in the world, and I meet them all the time, there's much more than that in the ENT world. Grommets placement and everything you hear every day in the UK that is being done. So now we think, okay, there's a direct link from ENT and what I do every day. So we are not that far off each other, but we never talk to each other.
Yeah.
It's completely separate discipline. So this is the problem with research. Everyone looks for their own. An orthodontist moves teeth, an ENT fixes the grommets. But where do we collaboratively work together? This is the whole. So there's no studies which connect disciplines. So we're all single islands, not communicate. We should build bridges between the islands, between dentists and orthodontists, because you speak a different language to me, because you might look into the bite and the functional occlusion, and you might screen for airway, because in the dental world, especially America, it's more popular to look for airway. And more dentists are doing it, doing MAPE, SAPE, dome.
Yeah, I mean, let's get into all of that. I think the problem is, Stefan, it's as you've touched on a couple of times in the conversation already, clinicians are scared, really. They're scared to use the wrong words. They're scared to say Airway when it's outside of my area of expertise. They said they don't know, probably they don't know the terminology sleep disorder breathing. They're certainly scared of, am I screening, am I diagnosing, and everything that goes alongside everything that you've just described.
But again, I do not diagnose sleep disorder breathing.
No.
I don't diagnose sleep apnea. I don't. But I see in front of me a risk. And if I feel the risk is high enough, it will justify a trigger for referral to someone who is diagnosing.
Mm-hmm.
This is your responsibility. Because if you don't, it gets missed. And if a kid stops breathing, you miss that. So, yes, we can put our head in the sand and says, oh, I don't know. I don't want to do airway. But let's talk about my son. My son had tonsillitis every month. I was every month in hospital. High fever, 41.2. Was standard. We didn't know what it is. We got told antibiotics, knock it down. Gut, gone. Every month. I was a dentist, I was an orthodontist, but there's my own son. You forget everything when it's your own son.
Mm-hmm.
You just be with him in hospital. Then at 6 months, he had meningitis, nearly died in my arms. So eventually, after 1 year of going from hospital to hospital, we got diagnosis, periodic fever syndrome. Okay, now we have a diagnosis. Makes you feel better, doesn't help you a lot. Same as my kid has that, ADHD. Okay, now you have ADHD, and now, does it make it better? No.
Mm-hmm.
So he got diagnosed with periodic fever syndrome. I moved to this country. Nobody knew about it. So again, for another 3 years, I went every month to A&E. And A&E is different to A&E in Germany. So antibiotics, gut health gone. No food, no nothing, lost weight every 4 months, every month. Until I found an ENT who said, I know that. I know periodic fever syndrome. We need to remove these tonsils. But NHS says 15 episodes a year for them to justify it. So, but I have every 4 weeks he's out of kindergarten, nursery, school, whatever. It affects your life. You have time of work. Said, so remove these tonsils and everything stopped. He was never ill. So that's when I realized, something is different. And then lockdown, everything happened in lockdown. I had time to actually use my brain and to educate, to podcast, read about it. And the first book I had in my hands was Tongue Tied, Richard Baxter. So you think, tongue tie. You do the exercise. My son might have a tongue tie. I had a tongue tie. Tongue was low, tonsil infection. So you start piecing it together. And then you suddenly think, oh my goodness, what am I doing? And I'll come back to these light bulbs moments I had, especially since I met Christian, because we are really dig down. He stimulates, we do research, we do everything. That was one of the light bulbs that said, okay, there's much more. It's not just the teeth. The teeth ultimately show you a symptom. Mouth breathing is a symptom. Posture is a symptom. Wear is a symptom of something deeper.
Mm-hmm.
And what is the first thing we do when we're born? We breathe. What's the second thing we do when we're born? We feed. Chewing, breathing. 2 key stimulus for craniofacial development.
Mm-hmm.
When does the swallowing reflex start? 16 weeks in utero. If that is not correct in utero, where's the tongue going to be? Low. What happens to the palate in utero? Narrow. Where's the jaw going to be? Back.
As a modern cosmetic dentist, I'm always looking for tools, techniques, and technologies that I can bring into my practice to have a meaningful impact on my patients' oral health. One area that I found frustrating to deal with up until now is early carious lesions. We've always had to monitor them, and inevitably in many patients it ends up with them needing a filling, and we've really not had a great tool to deal with this. That is until now. What we've recently implemented is Curodont Repair from Vivardis. It's a biomimetic peptide technology that can actually arrest or even reverse early areas of decay, meaning that patients don't need to have that filling that they really don't want. It's incredibly easy to apply and it's suitable for all age groups. So if you'd like to look at Vivardis as an option for minimally invasive care in your clinic, then go to www.professional.vivardis.com/contact point. That's professional.vivardis.com/contact point for 10% off your first case. Would it not be, why would the swallowing reflex not be correct in utero?
Because sometimes the cell death doesn't happen, so the tongue can't lift from the mandible off.
Right.
And now we can talk about the impact of folic acid into tongue tie. There's also research on it. There could be a link between that. Look at the supplements. Look at the diet our moms have.
So a folic acid deficiency in the mother,
correct,
while the child's in utero, has a potential link.
Yeah. Look at the diet changes we're facing. Look all the stuff that is in our food. Like we talk about longevity and what you're going to do, biohacking. Food is a big part of it. Mm-hmm. Breathing is a big part of it. But we don't eat good food and we don't breathe properly. And sleep is the next one. Mm-hmm. So we don't sleep properly. We don't have good food. So where are we going with this? Look at the statistics. ADHD, autism. 1 in 30 kids is autism. So every week I have autistic children in my practice. That's scary because some of them are nonverbal. So when you dig, you get quite anxious and sad because you understand this picture is much bigger than we think. Mm-hmm. And I understand, coming back to your question, professionals are scared. So was I. But we have opportunities. We thought by moving teeth, making them whiter, we help them. Yes, we help them for a minute. They smile in the mirror, great. But if you see opportunities in a child, in their growth and development, make them breathe properly, you get different reward. Because in my experience now the last few years, I have a kid that has Down syndrome, came to me with 9 years old. He was told his palate or his tongue is too big for his jaw. Tongue is out, frontal open bite. So I thought, well, I need to widen your palate because you had a cross bite. So I did widen the palate. Suddenly I get a message from the mom. Stefan, he stopped snoring. Oh, wow. You get that? I said, huh? Why is that? Then you read about it. Next message came a few weeks later. Stefan, I was just at the audiologist. He said, my son has movement in his inner ear, first time in his life. What? It's super emotional. So he could hear. So he stopped snoring and he started hearing. Nothing to do with teeth. So then I said, wow, okay, let's add another layer. Let's do nasal rinses. Let's get all the stuff out. Sonny says, Stefan, send me all the videos. He can breathe through his nose. And she could close his lips. He was on CPAP at 4 years old. He slept with a CPAP.
Jeez.
And if you think CPAP is the solution, put a CPAP on a child. This is a battle every night.
I can't imagine how the compliance for that would be.
Well, I can tell you. I have video as well. I was so direct contact with her because I was so engaged in this story. I said, let's try this. So she sent me video of him having CPAP on, falling asleep with the CPAP. Then she switched it on. The minute she switched it on, he pulled it off. It's on. I don't want to sleep with this. And also craniofacial development. A CPAP is a force on your face. Mm-hmm. Any forces is retractive. So it's not the right direction. Mm-hmm. So he was all red around his face every day. And wrong direction. He hated it. Every day a battle. But that's what he needed because he had no oxygen. So I just used the maxillary expander. It might be coincidental. I don't have evidence. He could breathe better. His ears opened up. He could hear. He started nasal breathing. And he started speaking. Because when you have a palate structure that's big enough for a tongue, maybe there's even speech. So that was for me something when I talk about him on stage, I get emotional like now, because these are things that touch you, because you're changing this life. And since I went on this journey and realized it's not the teeth you're doing this, these are lives you're changing, then it's so much reward that I never ever received in how many years in Harley Street, adult dentistry? 10 years? Never. And you might not get chocolate or bottle of wine or whatever, but you get a hug. And I can tell you story after story where I changed this family life. And I'm teaching a lot. And my wife always said to me, Stefan, what are you doing this for? I said, end of the day, most people don't actually care about you. Who cares about is your family. Your family, you need to be there for your young children. And so I said, when you die, who do you want by your grave? Definitely your kids, your wife, your family. You want to be seen as a good guy. And I said, yeah, Komal, you're absolutely right. Most of the adults I ever treated will not be there. But some of the kids I did treat now, they will. And that is, for me, I can live with this. If I made such an impact to some of these family life that they value their time to come to me to say goodbye, I'm done. I have done a good job. So now the only purpose I feel I have teaching everywhere, coming to your podcast, is to make people aware. Yes, it's scary because it's so much responsibility. But even if you start slowly and make small impacts, you mentioned your wife, Dr. Megan. She does now B-Bite, which is a myofunctional device, which can change a child's breathing habits. So this breathing suddenly through the nose can make a child change.
Yeah, I mean, she's got nothing as dramatic as what you've just described, but she's got multiple cases of kids, and she's only been using this device for a year or so, but similar scenarios where behaviorally the child is really struggling at school, no attention, bedwetting, snoring, grinding teeth.
Now you mentioned
all
your opportunities. You mentioned a lot of opportunities there already. They're not scary. No. They are the opportunities.
Yeah.
And it changed.
And the child used this device for just a couple of months and overachieving in school, got the headmaster's award for most improved, no bedwetting at all, no snoring. It's quite remarkable the impact that you can have.
How does that make you feel if that would be your prince or princess?
Oh, I mean, we had it with our daughter. She had terrible night terrors. And if anyone's had a child who's had a night terror, it's not a nightmare. I mean, they're inconsolable. They're hysterically crying, and their eyes are open, but they can't see you, and they're in this weird dream state.
Scary,
really scary, and you just have to hold them until it passes. She used to have those pretty regularly. I'd say probably once a week for a while, and we got her into the B-Bite after chatting with Miguel and the team over there, and I can't remember the last time that she's ever had one. And now she loves her B-Bite. I mean, she wears it every night.
You used an opportunity. You didn't know what you're doing, scary maybe, but you got a reward, so you will do it again. You get addicted to that outcome, and that is what you get. Because trying is not bad. You try, but if you do not try at all, you can only lose.
Yeah.
And this is what I say to all of the people out there. I understand you're scared, but my passion is to educate. I have teaching academy. I can train people to see the science. I can train people what tool to use to move structure. I can train. This is skill, which can be taught if you're open for change. Change is uncomfortable because the first lesson you will learn in the course is you don't know. I will tell you, you have no idea. My wife told me 10 years ago, you have no clue You are bad. You have no idea about functional occlusion. You don't ever seen your failure. I was number one in the world in Lingual. That was change. I could have said, who are you to tell me? But I wouldn't have married her after, would I? She told me I have a gap. And I used that opportunity to say, I need to fill this gap. When you get trained in university, we learn all of this stuff. And by the time we graduate, 50% is outdated. We don't know which 50% is outdated. So unless you unlearn and relearn, you will never grow. If you always do what you always did, you will always do what you always did.
Mm-hmm.
So you have to change.
Absolutely.
So there are opportunities, and it shouldn't come to that point like you and me, out of personal experience with their own children, that you think, actually, look, Stefan is talking about tooth grinding, bedwetting, tossing and turning, night terrors. Hold on a minute. This sounds like my kid. And that's happening all the time. I have professionals now who might be very much against the word airway, but they see symptoms and says, hold on a minute. Everything he says makes sense.
Mm-hmm. Well, many of my close dentist friends have sent their kids to you.
Right? So it makes sense. And it does make sense. But you need to be open and listen to other people and don't close them off. Everyone has a right to be. And going back to myofunctional therapy, 10 years ago when I came to this country, there was none. I wanted to do what I used to do in Germany. I had a myofunctional therapist in the practice. I came to England. Where are the kids? Where are the myofunctional therapists? There are none. So I said, okay, I do adults. There's nothing else for me to do.
Mm-hmm.
Only changed when I went back to kids 6 years ago. And I did them with aligners. I figured out aligners work well on kids. But that gradually I said, okay, where's my team now, my support team, my body workers, that I had to piece it together. And when we opened our clinic 5 years ago, I reached out to every professional in the area, said, I want to do prevention. I want to help children. Let's have a chat. Let's have some dinner. Let's have some drinks. I invite you, free education, free dinner. We had zero response.
Wow.
None. Whatever. We get laughed at. That's what is when you're successful. You get laughed at, you get attacked, and then they eventually follow. So now I said, okay, it doesn't bring anything to try to convince someone. We need to change something. We need to educate. So my social media changed. Now my social media is all about education of parents, because if they're seeing symptoms, I said, my child is doing that, the demand is growing. Mm-hmm. Because eventually they will go to them and says, my kid has this and this and this and this, help me. And when you get that once, twice, 10, 20 times, you say, hold a minute, what's going on here? This comes fairly frequent now. I don't know. And then eventually you say, I don't know. I should know. And Megan, she's a female females are generally born to do this prevention. I'm probably one of the only orthodontists who thinks in that way, I think. But as a female, they want to do kids. They love kids. They are very close to kids. And they see from a personal experience, the kids struggling. They go to a professional getting told there's nothing wrong. And they go from one
story that we hear over and over again.
All over again, every day. But the gut feeling, and moms are never wrong in the gut when it comes to their children. Never. But they're just getting calmed down, whatever. But when it happens and they come to consultation now in you, I warn them every time they come, says, do you know anything about me? About my philosophy? Because if they don't, I warn them, sit down. It's not about the teeth. I want you to get ready that I will connect dots, and you need to tell me when to stop. Because if I tell them the story of their child because of the symptoms I see, they will get emotional because they feel bad because they didn't intercept. They tried, but they got told there's nothing wrong.
Yeah, and this is the challenge, isn't it? That depending on where in the journey you're finding this individual, this parent, this child, the emotions that can come out of what you're talking about here can be very varied and very how do I describe this? Very intense, I guess. And
Super intense.
there can be a blaming of
A
the
lot.
various individuals that have been seen along the way, that
Absolutely.
through no fault of their own in most cases, they didn't have the awareness. And I mean, I'll be the first to admit that it's only over the last probably 3 or 4 years that Megan brought this to light through originally James Nestor's book and Jaws and other books such as that. The relationship between all of this. And when I was looking at mandibular repositioning devices for adults and those sorts of things, with Shark, I did some training with Shark Education from Canada, probably 5 years or so ago. But if a child came to me and they were grinding their teeth 5 years ago, I would say, well, obviously we can't make a night guard for a 5-year-old, so we'll have to just wait. They'll probably grow out of it. Don't worry about it. And that was a missed opportunity for me. And I think that's where a lot of the defensiveness comes from.
It's
because in the industry is that people don't want to admit where they have, not that they've been wrong, that they've now learned more and they've progressed forward in their knowledge.
I was speaking last week in front of 1,200 orthodontists. I showed my 3 children at the age of 2. That is where I got full custody of my 3 children. They lost their mom. I became a single dad in the country I never wanted to be in. My priorities were not the teeth of my children. It's life. I missed all the opportunities in my son who had fever every month, tonsil infection every month. I didn't think. I just was there for him, making sure he's safe. My own experience, I missed all of them. He nearly died in my arm. This is guilt. But I have to understand, everyone needs to accept, it's not my fault, it's nobody's fault. A dentist who has been trained in a certain way, wait and refer when all other teeth, that's not his fault. He didn't know. But what I blame people for, if they are not willing to accept, we can play a role in this. We can change, we can have the opportunity to learn, to unlearn, relearn, and just be open. I understand evidence is hard because control groups.
Well, that was going to be my next question, because obviously it will always come back to, what does the evidence say? How robust is the evidence in support of...
Look, there is evidence with certain case reports, which is always low evidence because there are no control groups. But how do I frame it? There is evidence that maxillary expansion improves airflow because it's physics. And there's evidence that maxillary expansion decreases airway resistance.
Yeah, bigger tube means more air.
Correct.
Straightforward physics.
That's evidence.
Yeah.
I don't say it improves airway because there's still a soft tissue. Adenoids, concha, polyps, allergies, whatever. But that's the evidence. So if I have a diagnosis of upper airway resistance, I know a maxillary expansion device can decrease that resistance. It's physics. So I need a diagnosis. So, but also now, I know you want to talk about extraction versus non-extraction. Let's think about that. We know that when airway gets obstructed for whatever reason it is, can be adenoids, can be whatever it is, we are posturing the head forward. Forward head posture. We see kids sleeping with a hyperextended neck. Because evidence, David Copperson published 5 degrees of compensation, 25 degrees airway volume increase. So we know we posture forward, that opens the airway. That's evidence. But what we don't look at is when we retract, does the posture change? We don't look at that. We just look at, is the airway volume different? And the research says it's not. But what happened with the body, we didn't look at.
Yeah.
We didn't look. So if we would actually do a studies saying, okay, we retract teeth, whatever. Does the body posture change? The NBC3 angle.
Is that not quite a straightforward study to do, though?
Has it been done? No.
Take the posture before the procedure is
But
carried
now
out and then do it
posture
afterwards?
needs to be reproducible. So now we have a lot of claims on their CBCT data. So you put a human being into a machine, there's a volume, you can measure it with AI, whatever, and then you do any kind of treatment, they claim we increased volume. But in 2 seconds, I give you increase in volume by posturing. There are so many people on stage who say they do Damon, whatever they do, and we increase the airway because it appears green. But they don't look, did the position, and you can change the position of how you put a patient into the machine immediately. Even up and down, swallowing has an impact.
Mouth open, mouth closed.
Where's the tongue? So you cannot use CBCT to prove airway. So there's a lot of things out there which I agree with the critics. That's not evidence. I agree with it. But what I see in children, some kids who struggle to breathe, they hyperextend the neck. They sleep like this. Kids with Down syndrome, what do? They hyperextend, put their finger in their mouth, push their tongue away. Why? Because the tongue will obstruct the airway. So they're doing first aid on themselves. We learn in first aid, when you have an obstruction of the airway, hyperextend, take the obstruction out and get air in. That's what they do every day. Look at what they naturally do by the body, because the brain needs protection. So if the brain doesn't have oxygen, they will adapt a new position automatically. Night terrors, tossing and turning. This is the brain waking someone up, says, there's something not good with me. I need to change the position. So we humans are so clever that we naturally tell the body how to position in order for us to give oxygen, because every cell needs the oxygen. So, but do we look in research about it? No. We say expansion or extraction doesn't affect airway. Correct. The data, the X-ray volume says the airway is the same. But we don't talk about it if the posture changed. And we didn't talk about how we position them in the first place. Nobody talks about it. Because kids are very good in compensation adaptation. And they don't ever talk about it. Then we grow into teenagers, eventually we get some symptoms. Grinding, wear. Sometimes kids have even TMJ lock. So the older we grow, the more symptoms we get. When we have a symptom, we might go to a dentist. Oh, my tooth cracked. Or
Have an onlay.
I have an online. So they do single tooth dentistry, I call it. They fix the tooth. What you learn from John Coy's, maybe it cracked because there was a functional trauma.
Non-working side interference or something like that.
Correct. So you learned it from John Coy's, but I would say, okay, there was interference, you learned that, but why did the interference happen? Because the teeth moved eventually. Why did the teeth move? Because of tongue. Why was the tongue there? Because of adenoids. Why would I say? Because of viruses. You can, if you understand the connections,
You get back to the root cause every
you
time.
get back, and that is your opportunity. The better you get into understanding where could be that root cause by asking questions, looking into the patient, the more you think, oh my goodness, wow, I have opportunities. And where was the opportunity early on? Function, lips, tongue, breathing. Myofunction, myobrace, B-bite, call it whatever you want. If you cannot treat a child, you can give them a B-bite or myobrace or froggy mouth or myomunchie, because you need chewing, lips. It's simple. Yeah. Also, what you know is, now when kids struggle to breastfeed, the mom immediately gets scared. My son, my daughter is not breastfeeding. They got lactation consultant. There's a tongue tie. Cut it. Done. Feed, breastfeed. Okay, sometimes it's good. But what about if there's not such an obvious tongue tie? They can feed, but the latch is not great. It gets sore. They really struggle. Then it's not so easy to say there's a tongue tie, because there's no obvious tongue tie. So then we go into the direction of mid-tongue restriction. So they're getting told, try harder.
The mother's getting told
Yes.
try harder to what?
Feed their
feed.
child. And because they feel bad, guilt, they try. So then I come along, says, yeah, your son has mid-tongue restriction. So hold a minute. I raised that at birth. I was trying to feed my son for 1 or 2 years. It was so hard.
Mid-tongue restriction, just define what that is.
Okay, good question. Most people understand anterior restriction because you get this heart shape. There's a tongue. The tissue is directly attached to the tip of your tongue.
It's visible from the front.
Very visible.
Yeah.
There's no mobility in the tongue. But when the restriction is further in the middle part of the tongue, they can't suck up.
Mm-hmm.
That's a mid-tongue restriction. That's very hard to diagnose. It's very difficult to grade it 1, 2, 3, 4. So it's a bit harder. So a lot of patients who had even a tongue tie release before, they develop scar tissue because there was no mobility. So then they developed a restriction further in the back, which is hard to diagnose. A lot of kids have a mid-tongue restriction. That means when they want to raise the tongue, it's hard for them. That means the brain needs a lot of energy to do this movement. So it's easier for the tongue to stay low. So they get used to that low tongue posture. So what happens to the muscle, to the palate? The cheeks are dominating in force. They're pushing it together.
Yeah.
So, and ultimately it was the tongue in the first place. So then you tell a parent there's a mid-tongue restriction. And they say, oh, I raised that, but I was told there's none. But to maybe the question you will have, does every tongue tie needs to be released or mid-tongue restriction? No. I want to give you an example, which is actually from my friend Christian. You will love him. Yeah. We have a car, and the car is the tongue. Okay?
Okay.
And we drive on the road, and we see a parking space on the right side. We want to park in there to get out of the road. So first of all, what we need is a parking space big enough. That parking space is the palate. So if you don't have a big enough palate, the car can't park. The tongue can't park in there.
Mm-hmm.
So it stays on the road, blocking the traffic.
Mm-hmm.
But what we also need in that car is an engine to move the car, which is muscles,
Mm-hmm.
strength. If the car never moved, there's no strength. But then we also have to check. So let's assume we have a big engine, we have a car parking space, so we could park.
Mm-hmm.
But then something is towed on the back of this car, which could be a restriction, like a tongue tie.
Mm-hmm.
But the tongue tie could be a chain, which you can't stretch, could be a toe, or could be a rubber band.
Mm-hmm.
We don't know. So it depends on what is on the back. Because if you have a big enough engine and you have a rubber band in the back, you can stretch that and still park in, get out of the traffic.
Mm-hmm.
So that means a tongue tie doesn't need to be cut. Depends on what the tongue tie is, or if it's a chain, a toe, or a rubber band.
Okay. You're going to have to unpack this analogy for me in a second.
So, but also what is really important is, in order for us to park the car in the parking space, we need to look at what size car we have.
Mm-hmm.
That means the size of tongue. And now this is where everything is changing. So data, we talk about, if you know a bit of these red flags, we look at intermolar distance.
Mm-hmm.
Correct?
Mm-hmm.
We want to achieve 38 and above millimeter intermolar distance, just as wide as a cotton roll. So you put a cotton roll into the molars.
Mm-hmm.
If that fits in there, great.
Success.
Very low risk for airway.
Okay.
If it doesn't fit, risk. So now, you need to understand the size of the car. You can drive a Mini, which doesn't require a big parking space. Or you can drive a V-Class, which needs more parking, or a lorry. So the car size changes. So your tongue size changes.
Mm-hmm.
How is your tongue size changing? By BMI. Body Mass Index. Fact. So if you're creating a 38 millimeter intermolar distance today, and the tongue fits, suction up out of the airway, massive airway improvement. And then something happens in life, they change diet, they gain weight. Suddenly, the tongue size will increase up to 30%. So that means the parking space that was sufficient is suddenly not sufficient anymore. So where's the tongue going to go? Low. What is if the tongue is not sucked in the roof of mouth and it's slow and you sleep on your back and we get fall REM and deep sleep, muscles become active, they fall into the airway. Obstruction. What's the research of highest amount of sleep apnea is BMI.
Mm-hmm.
So let's talk about this. The highest amount of sleep disorder breathing in children is tonsil adenoids.
Mm-hmm.
Looking at growth and development at university, we orthodontists, we're getting told when is the maxilla growing, when is the mandible growing. So we need to use puberty peak to move the mandible. 12, 13, whatever. We get told maxilla grows maximum before 10. Before 10. And then there's a curve in this Cromwell's curve of lymphoid system, which is peaking at about 10, 11. But the research on this Cromwell's curve is spleen. I don't care about the spleen. If you look at when do adenoids and tonsils, when do they grow, they peak at 7, 8. Look at my son. So if you're stimulating a tissue with virus or bacterial load, in the period where they want to grow most, they grow. So that's why the highest risk for kids not breathing is tonsil adenoids. So what should you do? Get rid of them. That's protocol. So the best way to improve sleep disorder breathing in young children is to remove the obstruction of adenoid tonsils if they increase. So ENT, big role. But now at 10, 8, 9, 10, it's plateauing. It's decreasing in size because the craniofacial complex is growing. This is where ENTs will tell you they might outgrow them.
Mm-hmm.
Have you heard that before?
Mm-hmm. Mm-hmm.
True. But they only will outgrow them if the midfacial complex gets a stimulus to grow. So class 3 cases. So basically, then we are reaching, called this curve, finish the curve. The plateau is called the honeymoon period of sleep disorder breathing.
Right.
Because between 10 and 13, they're plateauing. Kids will have no problem.
Because the face has outgrown the adenoids, in essence,
Correct.
and the tonsils.
But then, with poor diet, the nice school lunches they're getting,
Mm-hmm.
the nice sandwiches.
The tongue increases in size.
Why? Because the BMI is increasing. They're not moving anymore, the kids.
And so the tongue increases in size. Fat deposition happens within the tongue based on diet.
Correct. And around the throat.
Around the throat, I've always put 2 and 2 together. I've never thought about the fact that the tongue is fatter.
Nobody does. And that is the thing. We talk about we need 38 millimeter intermolar distance. I would say to you, forget data. The tongue needs to fit.
Mm.
So when it comes to children, I don't care about millimeters. I need functionality of the tongue. If I have a beautiful aligned expanded arch and the tongue still is overflowing the arch, I still didn't expand enough. Because the car doesn't fit.
Mm-hmm.
So the tongue will still stay low. So we need to change our mindset from static data-driven analysis to functional measurements. In your world, we have MOJO, functional bite assessment, which is real life, how do people move their jaw? Great. We're getting there with technology. We talked about technology at the beginning. We're getting more and more technology which allows us to check function. We have airway resistance tests in the nose.
Mm-hmm.
We can measure it. So we get more and more things which can prove I'm right.
So do you scan your tongues and do a volumetric analysis on them?
So theoretically, that would be a good idea. No, but I would love to. Because I need... but in which position do you measure the size of the tongue? That's difficult.
Mm-hmm. You need like a mod jaw, like a mod tongue.
But this is where we're talking about. But end of the day, you can do functional assessment, suction hold. You see if the tongue fits. Easy.
Like many of you, aligner treatment is a big part of my day-to-day clinical workflow. And one of the latest bits of technology I've implemented in my clinic to optimize this orthodontic treatment is dental monitoring. Dental monitoring is revolutionizing orthodontic care by bringing patient appointments to their phones. Leveraging clinically proven cutting-edge AI technology, dental monitoring helps me hit the sweet spot between optimizing patient care and treatment time efficiency. You can monitor patient compliance, hygiene, and aligner progress remotely while maintaining regular and professional contact with patients throughout their journey. It really is a big USP. Far better care with far fewer appointments. So if you're interested in joining me and upgrading the aligner journey for your patients, visit dentalmonitoring.com/contact point to learn more and get a special discount off your starter kit. That's dentalmonitoring.com/contact point for your special discount. Back to the show.
So now let's go back to orthodontics. Okay, I'm an orthodontist. Anger said 1899, class 2 diff 1 is caused by mouth breathing and nasal obstruction. Read it up. It's there. Where's the education gone? In all textbooks, it's class 1, 2, 3. Not about nasal obstruction. We forget about it. Then Tweed came, which was Engel's student. He said the faces Engel produces, I don't like. Based on like. I want a flatter profile. He introduced extractions and cephalometric. Said, I need a flatter profile, gives us better stability, looks better. So he introduced extractions. Based on what? On like. So this protocol, extraction versus non-extraction, is still debating. We're still debating nowadays, should we extract or not. I'm not saying I never extract. I don't say that. But what I will say is I try everything to create a bigger foundation in children to minimize the risk for extraction. And my experience in what the thousands of kids I treated is, if I do that well, I don't need to extract. If you come too late, sometimes I have to extract. And I did extract. I'm an orthodontist. I did extract premolars. But when my wife told me, have you seen your failures 30 years later? I don't need to wait 30 years later. I looked at some of my extraction cases when they came for retainer review. And what do teenagers not do? Wear retainers.
Mm-hmm.
So spaces behind the fixed retainer opened. Why? Because the tongue still didn't like it. So there's my failure in front of it. I just had to admit it, that was my failure. I didn't check it. I didn't respect, why were the teeth proclined? Because the tongue proclined them. If I don't treat the root cause, which is the tongue thrust will still be there. Just me putting them back and putting them in a cage doesn't make the tongue go away. Mm-hmm. But if the tongue can't go forward anymore because I'm retaining it long life, where's it going to go?
Back.
Maybe back. Maybe it can cause use loyalty problems or posture adaptation.
Mm-hmm.
So you need to look at your failures. Next example.
Can we just double click on the retention question for a second?
Oh yeah, interesting question.
Go on. Yeah, because it's one that I always think about, because I mean, obviously I do Invisalign in adults only. All of my patients get lifelong retention.
Are you ready for this?
I don't know, but I'm obviously aware of the conversation around get the teeth in the neutral zone, and you shouldn't need retention because balance should maintain the teeth where they should be.
You know who said that?
I don't.
Engel, 1899.
Really? So is that what you believe?
Not why, it's fact. I can prove it to you. If you treat kids, you understand the root cause, and let's assume the tongue was the reason it's sitting low. You expand the palate, give the tongue the space back. You train the tongue to become strong, no restriction, and enough space. And the tongue stays up. The tongue is your best retainer and your best expander. Every day. What is the biggest muscle in the mouth? Is the tongue. If you swallow 2,000 times a day and you squeeze the tongue up to the roof, this will develop your palate. So where it came to me is, my wife is restorative dentist. You do full mouth rehabilitation. Have you ever put them in long life retention after full mouth rehabilitation?
No.
Do you tell your patients you need a long life retainer, you have to wear it every night? No. But we do. What's the difference between restorative full mouth rehabilitation and movement?
Well, I guess in the short term, there's a muscle memory, to use very basic terms, to the PDL and the ligaments around the teeth, which would,
that's what they say.
If you didn't retain after the orthodontic movement, it would then, like an elastic band, ping those teeth back into the original position.
Is it the ligaments or is it the tongue and the cheeks and the lips?
That would make sense in terms of proclination or retraction, but what about in terms of rotation?
Okay, I'll give you a good example. Very good question. When it's actually an emotional comparison. My children lost their mom when they were 2 and 3. They have hardly any recollection of her. My Komal is their mom, the best mom I can wish for. When teeth are not on a surface yet, when in the bone, and you see sometimes in x-rays, they are rotated in the bone. There's crowding in the bone. They will come in rotated or shark position. If you are creating a bigger foundation, you know what the teeth are doing? They're coming in straight. Because they have no recollection where they're coming from. They think this is my new position. But once they see the surface, they know this is my home. If you now change the home, they will understand, I want to go back to that. So the earlier you catch it, the less likelihood is they will go back there. Because they have more time to adapt to their new environment.
So what you're saying is that the amount of bone around the teeth,
correct.
So almost like a intraosseous biological width,
correct,
needs to be maintained in order for the teeth to, or provided, in order for the teeth to not rotate.
Correct.
Okay.
And that's what you see.
Fascinating.
When you expand the foundation, we learn at university, the adult teeth come at 6 years old. And then the premolars come at 10, 11, 12, 13, whatever. If I would tell you, I can show you case after case of 9-year-old kids with phase 1, with full permanent dentition, 6 to 6 or 7 to 7. Then you say, hold on a minute. What did you do? You just created a bigger foundation for the teeth to come in. Mm-hmm. And suddenly they all go bum, 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 bum.
So does the body think that the child is older in essence because their jaws are of an older age child?
Everything's weird. So this is where I get a lot of critics sometimes to say, are you not scared to cause root resorption in moving kids' teeth? Then I say to them, this is completely unlogical. Because if a kid decides to put a finger in their mouth for habit, the teeth move. Mm. Do you get root resorption? No. The teeth move. All I do is I put a pressure on teeth. If it's an aligner, an expander, myobrace, whatever it is, it doesn't matter. Mm. It's a force. The tooth doesn't know what force it is, as long as it's low. So what the research actually shows is when you do teeth with not completed root formation, it accelerates the root formation. It speeds it up, the opposite.
Interesting.
And that's what you see. You creating foundation, in no time the teeth fall out and the new teeth come in. And guess what? They come in fairly straight. So I'm not saying I never do phase 2. Mm-hmm. But what I will say is whatever phase 2 I do is very limited and very short.
And just to define the terms that you're using there, because I don't think all of the listeners will necessarily understand phase 1 and phase 2. My simplistic understanding of what you're describing is phase 1 would be an early interception treatment, normally delivered, depending on how controversial you want to say, between, let's say, 4 to 7.
I would say 7 to
7 plus,
whatever
it is, early. And then phase 2 would be delivered around the normal
Correct.
in inverted commas, time frame around 12ish, that sort of
Yeah.
age. Fine.
So phase 1 is basically mixed dentition, and phase 2 is when permanent dentition is present. That's what it is.
Right.
So when you realize these are all these moments I experience, I says, this makes so much sense. And what I used to be told at university, what I was reading, is not true anymore.
Mm.
Also, if you would do the same study again, which defined the eruption pattern of teeth, nowadays, I'm very convinced that it would be 2 years later. Because most of the kids come to me, they're 8, they have no front teeth.
Mm.
They should have front teeth, but they're not. Because what evolution did and the processed food is we're shrinking. And what evolution does as well is the brain is increasing, craniofacial complex is decreasing. This is where our air goes in. So we have a problem. This requires more air. This gives us less air. What's the consequence?
Mm-hmm.
Look at the statistics. There's a consequence.
So if we can just pause for a second and just go into that shrinking of the craniofacial complex. You've defined already that you believe that to be down to breathing, diet, and lip seal. Is that right? Did I get that right?
would say it's epigenetic factors.
Yes, so post-birth factors in essence. Nurture over nature.
Some genetics, because if the mom has already a small structure, don't forget, what does prevention? Does prevention mean from 4 onwards? No. When you want to conceive a child, there's evidence that when you have not good nutrition, you're not as fertile. How about if I would say to you, if you suffer from sleep disorder breathing as a female, that could affect fertility as well? Maybe. So if the mother has a decreased oxygen saturation and you have a baby, the baby has decreased oxygen saturation in utero. What do every cell need to grow? Oxygen. What's growing most in utero? The brain. What's growing most post-birth? The brain. If from the mother already there's less oxygen, there's something not growing maybe as well in utero, then they're born with deficient structure. They're not getting as much air, so the brain still needs air. So you see, so when you go to fertility clinics, they check your blood, they check your hormones, they check your whatever vitamin level, they check your diet, they check lose weight. Don't drink alcohol, don't smoke. Who checks for sleep disorder breathing in women? Not so many. But maybe prevention should start with good oxygen from the mom who's giving the oxygen to their baby. So I'm just connecting, I'm just giving ideas. Yes, you can look at it, there's no evidence. We can look at evidence, there's no evidence. But just look at when structures are growing, what do they need to grow? And a lot of times they need oxygen. And matter of fact is the way we live our lives nowadays is not good for us. We don't move. Our diet is appalling. Yeah, we don't sleep well. We are exposed to stimulus all day, every day. So there's a lady called Beth Lambert in US. She has an organization called Documenting Hope. She's an incredible woman. Charity. She treats kids with autism and ADHD. And she makes kids with nonverbal autism speak. How? Change lifestyle. So she explained to me like that. 20 years ago, we have a barrel and all the stimulus we get over the day and stressors fill the barrel with water. Then we go home to our family environment, we sit on a table, we talk. We empty the barrel. Then we have a good night's sleep. We empty the barrel. So eventually, we wake up with the barrel empty, ready for a new day to start, full of stressors and stimuli. What's happening nowadays? A mom is full of stressors, doesn't sleep anymore, There's no conversation at dinner tables. Go in a restaurant nowadays, or families have their phones in their hand. No talking. So the barrel of water gets filled up, but there's no communication at home. There's no sport being released of stress. There's exposure to blue light. You do red light and you do everything of that. Why? Because of these reasons. So then they have a poor night's sleep. So they don't empty that barrel anymore. So they wake up with a barrel full of water. How much stress can you take the next day? Maybe not so much. Eventually, one drop, you tip over. Anxiety, depression. How many kids nowadays already suffer from this? The barrel is full. They have no way to empty it. This is sad. This is what Beth Lambert told me. Said, our job is to get rid of these toxins. Let them move. Have conversation with them. Change the diet. There's a lot of things we can do to help children get empty their barrel. Then they're ready for a new day, to have attention to soak it in, to grow in their brain. But we as a society, we need to wake up. And again, coming to back, it's scary. It is super scary. Because I noticed the amount of autism children coming to my clinic is scary. And you want to help them, but they can't even sit still. They can't even cope with a scanner in their mouth. They can't cope with putting an attachment on. So then you say, what am I doing? So then I refer them to people like Beth Lambert or Lara Barnes or Taiba, who deal with autism. They change the diet, cerebellum stimulus. There's a book called Unlock Autism. So there's things you can do, non-structurally, not expensive, maybe charity even, who help these children to come to a state where the barrel is not full. When the barrel is not full, they might be able to come to you sitting on a chair, be able to do diagnostic, which you need in order to help them develop the craniofacial complex. Because guess what? They're mouth breathing. Guess what? Their sleep is not great. Guess what? You should expand the palate, but you cannot. So this is all scary. And it is scary to me, especially if you discover, oh God, how is this linked? Now this, where do I start? Where do I end? End of the day, I'm a dentist and orthodontist. I do expanders. I move teeth. I don't do diet. I don't have time to do myofunctional therapy. I'm not a myofunctional therapist. So you realize this team is not you. You're just a piece of this puzzle.
Well, let's talk about your body workers then, as
right.
you call it.
And Airway is multifactorial. So the puzzle is big. And we talk about it. So now we talk about speech therapy, myofunctional therapy, osteopathy, craniofacial. Then you have fascia release. Then you have ENT. Yeah, you have whatever body worker. So here, every one of these body workers has a price. So I can refer your child to any of them. You should do craniosacral therapy before you expand to loosen the bone structure. You should have lymph drainage. You should fascia release first. I send you to the professionals, which I know. They all charge you, let's call it £200 for consultation. And 90 quid or 150 quid for a review. Now you add that up. Orthodontic consultation, myofunctional consultation, craniosacral consultation, fascia release consultation. You add up in a fee that might not be affordable for that individual. So then you get sad and you think, hold on a minute. In order for children to have good health, they need money. So health is a luxury good now. What about the people who don't have this? They don't have access to this system. So because if you do what I do, you get these people as well. So you want to have charge for your orthodontics. You want to have a charge for your myofunctional. But some can't afford. So then you're stuck. You stop. And says, no, you can't afford me. I don't treat you. Or do you say, you know what? Doesn't matter. I treat you anyway. That's your choice. So this is sad. This is emotional. This is scary. And this is my daily life. And I'm not blaming anyone who is scared of this. It's scary for me every day. The more I find out, and the more patients coming from the whole world flying to me, and they say to me, Simon, you're my last hope.
No pressure.
No pressure. Okay. I'm your last hope. But if you see potential in getting the opportunities, and you know some of the opportunities I see, I can help you with. But some opportunities has nothing to do with me. You need body workers. Then I can say, I can contribute my part. And guess what? We dentists play a huge role because the palate is the nose. And the air goes through the nose or through the mouth. So we have a part to play because all oxygen goes in there. And we orthodontists, yes, orthodontists, we change craniofacial complex. We should at least. We shouldn't wait till everything stopped growing. We are actually should have been trained in that. Dentists, I'm generalized now, they're actually not interested. They want to move adult teeth and restore them with bonding. Let them. But you, orthodontists, you should know how to manipulate growth. You should know how to use maxillary growth, suture growth. You know when mandibles are growing. Use it. Highest risk for sleep disorder breathing, retrognathic mandible. You think we should advance a mandible in puberty. That's what we've been told. We should do plastic aligners with bite blocks in teenagers. Which teenager wears a bite block? None. You get 1 to 2 millimeters of growth a year. If you have a 6 millimeter recessed lower jaw, you're not getting this done. If you have a 6 millimeter recessed jaw at 6, you have 2 millimeter each year, you get it done. Highest risk for sleep disorder breathing is retrognathic lower jaw. There's your opportunity. But we're getting told, wait till puberty peak. And then we're getting told by companies, use my product, they're perfect for teenagers. Removable devices with bite blocks on teenagers. Good luck. There's not much growth. They don't like it. So the success rate is very little. What should you do? Use the bite blocks on a kid because they grow much more, they adapt better, and you can decrease an overjet from 14 millimeter to 6 until they hit puberty. You have a chance. Every millimeter you get away from the airway is success. Less risk for sleep disorder breathing. Then we're getting told class 3s. Another favorite topic of mine. Real class 3, which is the fault is the lower. So we have a big lower jaw. And a pseudo class 3. Pseudo class 3 means the fault is in the upper. We have a recessed upper jaw. If you look at class 3s, a lot of them are recessed maxillas. Why? The tongue was always low. So when the tongue was low and you look at children, what they do at night, what they do with the tongue, you will see the tongue is sitting in the lower jaw all night. When do we grow most? At night. In which sleep phase do we grow most? When is the growth hormone being released? In deep sleep. There's a link to sleep, growing and sleep. And the stimulus that we receive in sleep is the key stimulus. So we need to check our children when we come home. How do they sleep? Is the tongue up? The stimulus goes to the maxilla, mid-face, great. If the tongue is low, the stimulus goes to the lower. It's not the fault of the lower, it's the fault of the tongue. But we have a recessed upper jaw. Third highest risk is recessed upper jaw, class 3s. The second highest risk is B-retrusive, when upper and lower are recessed.
Right.
That's fact. There's a study by Derek Mahoney, 3,671 children. He looked at facial structures. The kids with the highest AHI are recessed lower jaw. Second highest risk, recessed upper and lower. Third, recessed upper.
And AHI, just to find that again for those that aren't familiar with the term.
Apnea-hypno index. So basically, kids stop breathing. And guess what? The baseline is now 11. So if your child stops breathing 11 times an hour, it's bad. Christian Gimino, who discovered that word, that was his biggest regret he ever had to define that. Because if your child stops breathing once an hour, for me, it's enough to say, let's get going. Who says 11? It's based on insurance who pay out the money.
And on the class 3 point, in my mind anyway, in terms of my very basic orthodontic training, I was always taught that was very genetically linked, but the class 3. Now with our conversation now, I wonder, is the genetic component the tongue position, or is it something epigenetic altogether different?
Good question. I give you an example. I was teaching in an English conference about this topic, and the opinion from professors in the UK generally is most of the malocclusions are genetics. Let's call it 80-90%. 10% is epigenetics. I took a flight to Rome, was teaching at the university in Rome. The professor said to me, no. 90% is epigenetics. An hour and 10 flight, 2-hour flight, 2 different worlds. I said, huh? What I would say to that is, even if your belief is 10% is epigenetics, 90% is genetics, you have 10% opportunity. If your belief is 90% is epigenetics, you have a lot of opportunity. It doesn't matter. We can't discuss it all night, genetic versus epigenetic. Whatever epigenetic influence I can have with tools, I should take and not miss the opportunities. What do I try to say with that? When I have a class 3 bite, research is very clear, I cannot stop the mandible growing. And research is clear, I can't make it grow neither. I can't stop it, I can't make it. So forget the mandible.
Right. And that's the truth.
Look, when you deprogram a bite, you check where the mandible is going. And you need to take this CR position of the mandible. We learned at John Coyce. And this is your CR. This is how you make your clean check. If you don't do this, you mess it up anyway. That's what most dentists do. I don't want to offend anyone. But if you don't take your CR bite, you have a trouble. So, but what you can influence, which is evidence, is the maxilla. So, independent, I don't care if the mandible is genetically epigenetic class 3. But what I will treat, or at least try to, is guess what? The maxilla. Because I can expand it and I can protract it. Fact. So no matter what age, no matter if epigenetic, I will treat the maxilla expansion protraction. And I can show you case after case, I can fix it. They might be a bit more be protrusive, but from airway perspective, that's good because they're away from the airway. So now I'm asking you, when you have a class 3 and you restore them and you deprogram a class 3, what do you see? What is the lower jaw doing?
When you deprogram,
when you open the vertical with any device, Lucia check,
it's going to go backwards and upwards, isn't it?
So now think about it. So that means what you just told me, the lower jaw is going back. So it is functionally adapted forward, correct? So MIP is further anterior than your CR. In kids, it's exactly the same. This cephalometric we take to diagnose skeletal classes.
When they're in that position anyway, yeah.
They are in a static MIP position, not in CR. So how true is the cephalometric tracing?
Only as true as the position that it was taken in.
Correct. So it's flawed. How many mistakes do you make in cephalometric tracing? I give you 10 people cephalometric x-rays. They all have different values. I give 10 different AI softwares, the same x-ray, 10 different values. It's flawed left, right, and center. But nevertheless, we base our treatment decisions on the data from the cephalometric. Isn't that scary?
And carry out surgery based on the position based on it as well.
So now, good point. What surgery would you say you need when the B point SNB, which is a mandible, is prognostic and it's a real class 3? What surgery are you going to do? You cut the lower, move the lower back.
Mm-hmm.
So what would I say to you if functionally it's actually further back?
You're going to increase the risk of sleep apnea.
Bam. So I just had a surgery case last week. Suggestion, NHS, cut lower jaw back. Guess what the surgeon Barcelona did, who is Airway aware?
Forward.
Counterclockwise rotation, forward.
Yeah, I've seen the impact of orthognathic bringing forward on the sleep apnea stats. It's quite
face,
remarkable.
on everything, how they look, on the nose. Basically, we live in an era of technology. We have mojo, we have all of these things. We need to start questioning, is what we always used to do, maybe
wasn't the best.
Is a bit outdated now. So if you always do what you always did, you always get what you always got. Same back. So when I dig all this, I question my own profession. I'm the orthodontist here. I was the one who said, the Bible says, I look at cephalometric tracing, study model analysis, but you do facial analysis, you do mojo, you do an CBCT with Airway. You dentists do different diagnostic than me. So, language. We don't have the same language. So your target is different to my target. What's the biggest problem? If you refer a case to an orthodontist for your restorative purposes, you get it back in the wrong position. Has that happened to you?
Yep.
Right? They might have extracted, they might have moved into class 1, which was functionally unstable. So you couldn't restore. That's exactly what my wife told me. So I had to learn something is not right here. And I tap on my back and says, I achieved a class 1. You can't tell me anything. I have a class 1. So what's happening? When I speak to dentists in COIS, why do you do aligners? Because they said the orthodontist is not good enough. So I said, oh dear. So I had to realize, if I would say to you, Simon, you give me the orthodontics, I give you all the spaces in a perfect bite and you do 20 veneers on this case. After, would you take the orthodontics or would you just take the 20 veneers? Where do you make the money, the 20 veneers? You are restorative. Your passion is generally, initially, that's why we came to who you are, restorative dentistry. You were more or less told by companies you can do orthodontics, and you were more or less forced to do orthodontics because the results you were receiving was not good enough.
Well, I think dentists are also control freaks and they want to control every step.
Correct. But you don't need to control every step if you trust the person who's doing it. Because you trust the person. You don't need to control him. You know, like my wife never touched
the same language, don't you?
Never touched an orthodontic case. She says, Stefan, this is what I want. What do you need to do to achieve that? How predictable is that movement? How long will it take? Then I can say to her, let's talk about curve of speed, deep bite. She says, I need 4 millimeters of intrusion of the upper front teeth because my COIS facial analyzer told me I need to intrude 4 millimeter. I say to her, that's very good for you, but for me, 4 millimeters is nearly impossible. If I use aligners, tats, whatever. It takes me 2-3 years and root resolve, whatever. So I can then say to you, okay, Komal or Simon, I can give you 2 in that period of time. Is that enough? Then you might need to do crown lengthening. This is conversation. So this is how it should be community. We need to speak the same language, and you need to understand my limitation and expectations. But this is not happening. There's no communication. The targets, the goals are different. This is what Christian is a restorative dentist. Our goal is to build bridges between disciplines. We have the same goal. We should have the same goal. And when we look at the pyramid of treatment, we said function, biomechanics, perio, everything is in the pyramid of treatment planning, facial treatment planning. But now at the rock bottom of this pyramid is what? Airway. Because if we forget the airway, we might have a problem. Because if we move into the wrong direction, it's going to be wrong anyway. And an eye-opener case for Christian was a case with a lot of spaces. And easy with aligners, right? You press your eye button, clean check, AI generated, approve, your teeth get retracted, you fit the aligners, push the teeth back, you could end up with constriction, TMJ, symptom, but if it's really bad, you could suddenly turn up with an AHI of 29. That happened to Christian. Suddenly, this patient said, I don't sleep anymore. He said, huh? He had a sleep test before, and he had a sleep test after orthodontics. He caused AHI increase. So he says, oh dear God. So what did he have to do? Open it back up. So this is where he said, I need to do this. I need to understand this. We need diagnostics. And diagnostics nowadays is not just facial analysis, perio, biomechanics, perio, structure, and face. We need to look at the airway as well. This needs to be part of our diagnostic protocol. This needs to be trained. And yes, it's scary, but it's not as scary. A sleep test, you can home sleep test, watch pad, sleep image. There are things which give you a sleep test. You need to understand how to read it. So you can assess risk. But you need to understand is what's going to happen with my cartoon that I have in front of me if I do this movement. I have more jaw. They show you how the jaws are moving in function. So if you have interference in the front and you move them more into interference, you get a problem. And the latest you will realize this is when you come back with lateral open bite. How many cases do I treat of them fixing problems? Every week. Because a company makes it very easy for you to press a button. 80-90% of buttons are pressed in first.
Really?
So no input. So it's risky. It can work. 70-80% might work for short term, but 20% might not work so well. They get symptoms. Then you have a problem in the practice, which you can't handle. Complaint, or your bonding's chipping, or whatever. I worked long enough in the industry in London with all of these people doing bonding all day long, fixing the bondings a few months later. Because it's functional problems, and they don't even know about airway yet because they're not aware. We need to become aware there's air.
So let's. I'm keen to make sure, because you've delivered a huge amount of information, and I'm quite aware of this topic already, and I feel like I've learnt a huge amount in our chat already today. But I do want to make sure that the listeners leave with maybe 3 top action points, and we need to be, I guess, specific here. And I want to get on a bit more to adult stuff in a second as well, because I've got some more questions there. But in terms of the kids, let's say for the GDPs listening, for the general dentists, what are the 3 things that they should implement in their practicing lives on, we'll say Tuesday morning, because it's a bank holiday on Monday, that can make a meaningful impact in helping these kids? Because they're not going to be able to treat it straight away. They're not going to be able to do the early inception orthodontics that you do straight away. What can they do?
Number 1 is learn screening tools. So I'm the orthodontic specialist. You can come to me. I send you the list, 14 points. You see what it is. If you don't understand what it means, malampati or tongue tie, you can read about it. Surusagi Breathe Institute LA.
Is that available online somewhere?
Absolutely.
Can we put that in the show notes or something?
Yeah,
like
so I
that
can
link?
send you my screening tool, no problem.
Brilliant, that'd be great.
Yeah. Otherwise, it's the Ferris 6 from Surusagi published. Breathe Institute in LA, Stanford University.
Right.
Ferris 6, this is where my assessment is based on. Now it's Ferris, in adults, it's Ferris 6 plus 4. It's all there.
Okay.
Free available. So you start screening. Breathe Institute in LA. Surusagi. So you screen, then you have you count the red flags. If you have moderate or high risk in red flags, because you counted red flags, you know, okay, there could be an issue. That's it. If you're not confident in doing anything about it, refer to someone who is. If you want to learn more about it, I'm here.
Mm-hmm.
Yeah, we have a teaching academy. My passion is to teach dentists. If orthodontists want to, they are welcome. Pediatric dentists to learn screening tools, and if they want to learn the tools how to treat it. We talk about adults in a minute.
Mm-hmm.
In kids, it comes down to aligners and maxillary expander. Easy. Aligners are 3D metal printed devices. They fit like nothing. Aligners are easy. There are companies out there now who have even myofunctional trainers with the aligners.
Mm-hmm.
So it's happening. I'm very much involved in this space. I want kids to have good access to aligner companies.
And so the dentist should be making the diagnosis on the tongue ties?
No diagnosis, no.
No.
Dentists should assess a risk.
Even for intraoral characteristics?
Absolutely.
Okay.
They say, what if they don't know the classification of tongue tie, you can learn. If you're not sure, then you're not sure. Okay? But then you refer to someone who can do it. The diagnosis, also me, myself, I don't diagnose tongue tie. Because tongue tie diagnosis consists of my diagnosis, a myofunctional therapist diagnosis, and the surgeon who's going to release it.
Right.
If all three of them feel there's a need for release, you release. This is best protocol.
Mm-hmm.
Because if they're not prepared well for the release, you can't release because it gets reattached. So this is a topic itself. So if you want to know about tongue tie, go to Sarusagi Breathe Institute, 3-4 days, you will learn everything. Yeah, he does it online, everything. Best address. Yeah, if you want to do tongue tie releases, go to him as well. His best address, Richard Baxter is another one. Yeah, they will teach you tongue tie assessment. But tongue tie only plays 4-5% of the picture.
Okay.
That's not the big part.
Mm-hmm.
The craniofacial complex, the narrow, high palate. That's a big point. Also, mouth breathing is not big. A high vaulted palate where the tongue doesn't fit in. This is a big one. If you can't expand, there will be people like me who do.
The parking space.
Parking space. Because otherwise you stand on the road blocking the whole traffic.
Yeah.
That's exactly it. So your job is not to diagnose. You are not an airway dentist. You're not an airway orthodontist. Your job is to assess, is there any risk?
Mm-hmm.
And whenever you plan a case, could that negatively impact my parking space? If it does, either you get a smaller car, which is hard, yeah, or you accommodate that car. But don't decrease the parking space because the tongue will not park in there.
Okay. So screen every child using your 14-point test
Or the 6.
or
Yeah.
the 6-point test from the Breathe Institute. And then where you see whatever the appropriate number of these red flags is, you're then going to be referring to an interceptive orthodontist such as yourself.
Well, there are not many who do that.
Which is the challenge. Or you're going to train yourself up. And then do any of the sorry to interrupt, but do any of the red flags, do they also indicate a referral to a sleep physician?
Absolutely.
An ENT surgeon?
Correct.
Is that all clear within the screening structure?
The minute you feel there is a high risk, you need to refer to an ENT. That's your obligation. And if you have done diagnostic like X-ray, you send them with it.
Mm-hmm.
That's the first point. That's his duty. You need to refer. Sometimes you're not getting anywhere with it because you have to wait God knows how long and they popping you off. But you have to do that.
Mm-hmm.
Yeah. So you need to refer to an ENT if you see anything. Even if you have a child and it looks not happy, we call it venous pooling.
Mm-hmm.
Yeah. Tired face.
Dark circles around the eyes. Yeah.
Behavior problems. Tossing, turning. You mentioned night terrors. These are all red flags. Then you say, oh, look, this child is not doing so great. I don't know, but I know something can be done. But I can't do it yet, so I want to refer to someone who can screen you. This is the biggest thing and best thing you can ever do. And if they come to my office, I will say to them, give whoever referred you a bunch of flowers. Today, midwife who spotted on their friends' kids, you are tongue-tied, 11 or 8 years old. So she came to me, I told her everything, she had sleep apnea. The midwife said, who is their midwife? Buy her a bunch of flowers today, because she flagged up there might be tongue tie that might cause you a problem. So your job is not to do everything. Nobody expects you to do that. But if you are concerned, if your gut feeling tells you something is not right, and there's people who talk about it, there can be help. At least give them the opportunity to get that access to that help.
Mm-hmm.
This is what you should do. And then, if you want to, you can get knowledge. Knowledge is not free, but it's available. And then you can develop your skill. And I tell you, everyone who came through my program in kids never ever regretted it. I have people who changed their whole career from adults to kids because they felt so passionate about what they're doing. I have a 30-year-old young dentist who opens her own clinic now in Belgium based on kids.
I'm not surprised. I mean, as you say, the impact that you can make is quite remarkable, isn't it?
Absolutely.
Of everything that we can do with our profession, it's got to be one of the biggest.
It's not a line bleach bond. This, I can tell you, this is so much bigger than that. To see these kids thriving, growing, behavior changes. Like we had yesterday a teenager who said to us after we started expansion, snoring gone, jawline developed, is performance increase. This is 3 weeks into treatment. I mean, this is emotional. You know?
And just to reinforce the point, I think we have to remember that for us as dental healthcare professionals, we're one of the few health professionals in the world that get an opportunity to see these kids on a regular basis every 6 months. Nobody else is seeing them unless there's a problem. So if it's not us, then who is it? And I think as we started the conversation with, yes, there's concerns, yes, there's animosity surrounding this debate. I certainly feel that anyway. But actually, as you say, isn't it worth that animosity to have the potential impact that can be had?
I really like what you just said. Look, my goal in everything being exposed is not to fight.
No.
My goal is to tell people there are opportunities. And my core intention is to anything I do is to try to help the community, the kids predominantly. Now I do adults as well. To live a better life, a healthier life. You do that in your lifestyle changes as well. You will do that with your own children. There's nothing bad in that. To try your best and your opportunities to use them. Yes, it needs to be based on evidence, but the evidence is very limited at the moment. But just because there's no evidence doesn't mean there's no evidence. It's just not there yet. Like a lot of orthodontic things we do are not based on evidence. They're based on case reports. It worked, so we're doing it. There's no evidence. So this is a whole orthodontic profession. So
I guess it's also risk reward with expansion in kids.
Yep, I'm
what
not saying
what would the perceived risks of expanding early be?
Just to clarify, I'm not expanding every case. I expand if I see a benefit and a risk. So then I expand, but I'm very aware of my guideline IOTN. And if parents don't classify to IOTN of 4 or 5, legally, I should not treat. But if there are symptoms that make me concerned, I will tell parents I'm concerned about these symptoms, but it's their choice if they want to intercept or not. It's end of the day, my job as a clinician is not to decide. My job is to give every opportunity and option that is available out there to the parents who decide. And I feel this is not always the case. The parents getting told we need to extract. That might be one option, but the other option could be to do a MAPE, minuscule assisted palatal expansion. That's another option. Or instead of taking a canine out to try to expose and bond it, there's always other options. The problem is maybe the option you don't have the skill to offer that option. But that's okay. You don't need to have every skill set. Nobody asks that you can do lingual, buccal, aligners, 3D printed, mini screws. You're limited. You can choose to learn upskill, but that's your choice. But my education is based on they diagnose, they treatment plan, and they give all options. And if they can't give the option they want, that's okay. I will refer to a professional who can.
Mm-hmm.
I don't do veneers. I tell them you will need veneers when I open you the spaces, but it's not going to be me. I can refer to Simon, I can refer to Koma. I don't care. It's not me. I don't do fillings. I refer to someone else. The goal is not to be by yourself and do everything.
Mm.
The power is to connect, to appreciate the other people. If there are people like Megan who likes beat bite, that has a thing, especially for young children. Big benefit, because sometimes they can't afford or there's not a mass need. But with these devices, they do slow progress structurally. Because you need to change the function to get structural change. That takes time. I create structural changes quick. So if a child is not breathing properly and they need structural changes to improve airflow and decrease airway resistance, I can do that quick. MyoBrace or B-Bite will do that slow with good compliance. Compliance over a long period of time drops. We know that from aligner world. So we need to be careful to appreciate what I call always efficiency. If you're a good clinician, if you have the tools in your toolbox to be efficient. A lot of times I do upper, lingual, lower aligners or whatever I do, because that's the most effective way to treat it. A dentist is fairly limited, sorry to say, with aligners. So they reach certain limitations in movement, biomechanics, but that's okay if they have another bodywork or team player in their team to do this time of that. This is how we work together collaboratively, and that can work well. Everyone should be good in their own discipline. But what I felt, especially last few years in London, is everyone is doing everything. So I do aligners, I do bleaching, I do bonding, okay, you're good in every discipline. You might be. But working together is beautiful. It creates friendships. It becomes nice relationships. And what it does when you treat kids, it connects. How do you connect with your peers if you're just a single player? You know, putting your elbows out. That's not what I like. I don't like it. And that's also part of the reason why I left London. They're so full of people who feel whatever they want to feel like. That's not me. I like to share my passion because end of the day, you help me to get this message out there. I appreciate that because only together we can help all of these people. And whatever we do, my mission is to help children. Every decision I make is to help children. And there's nothing bad about it. I don't want to attack. If I get attacked, I normally respond with love. If they continue attacking, I said, look, this is not for me. You know, it's your opinion, but I don't need to share your opinion. But I get it every day because if you're successful, you get attacked. That is their own problem, their own reasons why they do that. But I know full well that I try every day to do my best to help these children. And my team loves me. And that's ultimately my children, my family, my team loves me and my patients love me. And then nobody can take that away from me. So if I offended anyone, I'm sorry. That was not my intention. But I want to help, and I'm sure you want to talk about adults a bit, but there's nothing wrong with this.
Yeah. And I think you've approached it from as you say, from a place of love. It's not, you're not looking to blame anyone. You're not saying anyone's done anything wrong. It's more just, and it's the ethos of this podcast really, which is we have to be adaptable to change. We have to be open to new information as it presents itself to us, and we have to be willing to look at the new information and make changes appropriately. And so, if we don't do that, we're doing our patients a disservice.
Absolutely.
And as we've said already, what an amazing impact we can have. But I do want to get on to the adults just very briefly. I know I can see in the way that you speak that kids is your passion and the impact that we can have there. And from everything that you've said, of course, that's where we should focus because actually everything is downstream from there. But for those patients that are my age, older, younger. They've moved past the growing phase of their lives, and they're coming in. For example, I can think of many patients that I've seen over the years that have spacing and quite wide jaws already. What do you recommend in those sorts of cases to those sorts of patients? Because obviously, just doing restorative in that scenario is going to lead to very wide teeth.
So look, the reason when you talk about the spacing case, wide arches with spacing, is the tongue.
Mm-hmm.
So, and that means you need to train the tongue to work correctly. Swallowing, tongue posture, tongue muscle. This is a good thing. So if you do something, it's myofunction.
Interesting. Okay.
Because a muscle that is strong is less likely to collapse. Fact. There's research about this.
Mm-hmm.
So if you cannot change any structural things, you can change the muscle. Move. Get it moving. In kids as in adults. That's easy. It's free.
And so is a weak tongue a wide tongue?
Weak tongue can be wide because it sits flat.
Mm-hmm.
And then it goes into your airway.
Right.
Yeah. And when the tongue is moving, there's muscle, there's less fat. Same as your body.
Right.
So that's what you can do. But when you think about restorative ways, is when you ignore the tongue and you restrict the space, you have a bad awakening. You can't do that. You need to consider the tongue. The tongue, Garliner called the tongue the enemy of an orthodontist. Look at open bite cases or spacing cases. They relapse all the time because nobody treats the tongue. 40% of surgery cases for open bite relapse. Fact. But who treats the tongue? Fact is also, if you implement myofunctional therapy, the relapse is decreased by 15%. So it's research. So, but I would like rather talk about the upper cases who have a narrow palate, who have TMJ, who have wear facets, who have destruction, and they come to your office every year with another tooth broken, another tooth decay. We think tooth decay is only related to diet. No. Could be dry mouth. Why is the mouth dry? Because there's no saliva, mouth clean. So there's much more. But what can we do? So in adults, we can expand a palate in adults. Yeah, we call this MARPE, or the new word is MASPE. Yeah, MARPE is mini screw assisted rapid palatal expansion.
Minuscule.
Mini screw.
Mini screw, sorry.
Mini screw assisted palatal expansion, rapid.
Right.
But nothing nowadays is rapid anymore because we have mini screws. So we have direct bone anchor where we have direct force application to the bone, not on the teeth like we used to.
So 4 TADs in the middle
4,
of the palate.
6, 8, 10.
And we apply pressure against those.
Correct. So in US, some people providers do 8 or 10 mini screws. So now we call this MASPE, mini screw assisted slow palatal expansion, because we're turning slow. Okay, there's so many words for the same thing. Mini screw assisted palatal expansion. Okay, so now in females, the suture opens, you can count nearly in all females, independent from age. Game changer. So the palatal suture is not fusing in females. Why? Females have children. There's no suture fusing anywhere because they are having children. They need to be ready. That's my theory. The problem is with adult maxillary expansion is male. Males under 25 generally open. Above 25, they might not open. Then you can't do a mini screw assisted palatal expansion. You might do a surgical assisted palatal expansion. So you need to cut. What do you cut? Different structures in the bone that cause a lot of resistance. Yeah, I love the dome technique. It's the distraction osteogenesis maxillary expansion. Dome.
Distraction, osteogenesis, maxillary expansion.
Correct.
Right.
dome means nothing different. And Christian, he optimized, I'm sure you will talk about him with him. We use a guide and we cut certain structures that cause us maximum resistance on the bone. So the rheumaticus bone. So you go with piezo in there, weaken it, another guide. Then you do the expansion. So that means they decrease the resistance and then they open.
So you're not just going down the midline suture?
Sometimes you can do that. That's enough. But the problem is the maxilla is attached on other structures with sutures.
Right.
So then you don't know where the sutures are weakening. It could be up there, could be here, could be here.
So it's risky.
So it can cause side effects, which you can handle, but you don't want them. You don't want that your eye can drop, something like this. This is a situation where you don't want.
No, that's not a good one.
So to minimize the risk, AutoUne has a really good presentation about the side effects and how to deal with it. So you cut a specific point to minimize the risk. This is Christian all over. So there's things you can do, but the cases are very rare who need that. They're the male, the rugby players, solid bone. Don't even try to open them. Yeah, but most of the population, especially with the time we live in with social media, these teenagers out there, they have AI, TikTok, all sorts of things. They're getting told, for example, mewing, whatever. They're getting seen these jawlines, these beauty ideals.
Look maxing.
Yeah. They're coming in. Oh my goodness, you can't believe the demand.
I've seen them talking about the MARP and showing their TADs on. I mean, I'm not on TikTok, but I saw a clip somewhere of them talking about it.
It's full. So what is really important to understand is before you do anything, you need diagnostics. Without, it's not a short thing. Diagnostic consists of all the facial insights, diagnostic, perio, everything. Sleep test is a big part of it, and motor functional assessment. So before you get anything, you need diagnosis, because without diagnosis, if you can actually help this individual, you're not doing anything. This is key for us. We spend a lot of time in creating a virtual avatar of a patient, which is possible nowadays with the technology. And then we discuss where is the biggest problem, where's the low-hanging fruit we can treat easier. Sometimes it's myofunctional therapy. Listen, get your diet in gear, train your muscle, you might be good. That's easy. Yeah, before we go into these complex treatments. But unfortunately, the belief is out there, you do these movements and your jawline is growing. That's not the case. So in an ideal world, there's a lot of solutions, but the longer you wait, the more you need to invest in diagnostic and treatments. So compensation is the tax you pay when prevention fails. So the biggest gift you can give is let your children be checked. Because you can restore them the minute you see signs. The longer you compensate, the more you pay. That's the same in dentistry. So if you can change one thing in your practices, go screen. And this is your podcast. Where are we going in 10 years? If everyone would screen for signs of these things, pediatric sleep disorder, breathing, and treat the structure early enough so the teeth come in straight with good balance of the muscle, tongue, cheeks, everything. The teeth are most likely to have less decay because of saliva content, less obstruction, less cracks, less problems restoratively. So unfortunately for dentists, there's much less to do.
Less dentistry.
But what's your goal?
Yeah.
What's your goal is not to fix. There's still hundreds of years until this happens.
And
if
lucky.
I do, so, but if we do just a small percentage of that, that would make me very happy. But the key where we're going is Airway to screen. This needs to be part of our protocol, especially you as a general practitioner. When you see young children, family dentists, you have the opportunities. As an orthodontist, it's not even our fault. We get patients referred too late.
Yeah.
We see them for 2-3 years. We never see them early, and we never see our failures. We don't. It's not our fault that we do what we always did, because that's what we were told. So for the orthodontists out there, it's okay. But now you know. When you know and you see, you have to do better. That's what John Coyce always says. When you know, you need to do better. So that's where I feel this is where we're going. And the more doctors, dentists like your wife who are passionate about something and spread the awareness of this need, the better, because it's to the benefit of our own children who eventually support us later on in life. Otherwise, if they are all depressed, anxiety, autism, where are we heading towards? Who's going to support us? How do they live a life on their own? I mean, this is not a good direction. So this is for me dentistry. Dentistry is prevention. Dentistry is health. Dentistry is biohacking. Dentistry is going back to our roots. And lastly, I want to share an experience. My wife is Indian from Punjab. And last year, I had the pleasure to go to Punjab first time in my life, into rural area of Punjab, not cities, and with charity work with local schools. And I checked, of course, the kids' teeth. There's no problem. No exposure to television, no phones, no junk food, nothing. And then I woke up at 6 o'clock in the morning. The uncle of my wife was sitting there. He goes 5 o'clock to the temple, sees sunlight, sunrise, does his prayers, gratitude, goes for a walk, movement, goes back home, and he does breathing exercises, pranayama breathing exercise, Indian, left nostril, right nostril. And then he started doing tongue exercises, left, right, up, down. And I was sitting there with my mouth open saying, what is this? And I said to him, what are you doing? I teach in the whole world what you just did. How long are you doing that for? I said, all my life. It clarifies my brain.
Fascinating.
I was like, wow, where has it come down to? This modern world. You need technology, AI, great. But we need to go back to basic life. And this was for me eye-opening and beautiful, and
yeah, it is beautiful.
I'm very grateful that I'm here today.
Well, you're doing a great thing, Stefan, and it's as I say, it's a really important message, and I couldn't agree more. I think many of the issues that we are presented with in modern society are as a result of the structure of modern society, and many of those issues could be resolved by going back to how things used to be done. There's many things that we shouldn't go back to the way things used to be done, but in terms of how we connect with nature, how we focus on the key pillars of life around light and airways, breathing, food, connection with the earth, connection with nature, all of these things I think have a much larger role to play than anyone gives them credit for. I look forward to hopefully seeing a huge increase in awareness of this in the UK, especially where I think it's needed most.
It's a worldwide problem. I mean, if you think UK is a problem, US is the same problem. The only thing is US is a big country. So the people who are aware and presenting themselves on social media are high, but considering the size of the country, it's low.
Really? Yeah, because certainly when I speak to my American colleagues, and I'm on quite a few sort of international groups, terms like MARP and DOME are used without definition. They're used in a assumptive manner where they just assume that everyone knows what they mean. I would imagine the understanding of the definition of MARP in the UK in the dental profession is maybe 1% would know what it means and stands for. But as you say, I mean, I guess that's an echo chamber of KOLs and individuals that are talking about these types of treatments.
And these are dental colleagues you're mentioning. The orthodontics in the US are far away from this.
Really?
Yeah. The AO white paper is saying initially we don't play a role. Now they at least said we can play a role. So, but now next week I'm on my way to New York because that's where the people are aware to speak on the Paediatric Airway Congress. So, unfortunately, I would love this to change, that people are more receptive to listening to this, because I don't necessarily like to travel to Shanghai, to New York to be heard. You know, like there's so much need here in this country, and there's so much which we can help with. So it would be lovely to see more people getting education to start screening, and we can teach them what to do. So, yeah, but there's a long way to go.
Well, it's exciting times, and you're making a big change and a positive change at that. The way that we like to finish the podcast is to look at two things. Obviously, our focus is towards the next 10 years in dentistry. I think we've spoken about many of these already today, but if you had to crystallize it down into two, what would you say is a fad for the next 10 years in dentistry? And what do you think is the future of dentistry in the next 10 years that you're most excited about?
What I'm very excited about is what impact technology can play in future to prove I'm right.
How do you think it's going to do that?
Measuring tools and AI tools that will be soon available, which can do myofunctional therapy to anyone in the world, wherever they are in the world, at the time they want.
Fascinating.
So because it starts with lips, tongue, and breathing. So if I can get access, everyone has internet nowadays, so they have access to data, to a platform. So if I can give to most remote areas who start degrading because of lifestyle to these exercises, I can prevent a lot already. This technology pure, and they don't need to come for this. So the role technology to measure data and to create evidence, I'm excited about. And there's so much coming. The speed is crazy. AI is amazing. This is what I'm excited about. I think the other part is, if you believe that bonding is the future of dentistry, think twice. Yeah.
Not a fan of bonding.
I'm not a fan of presenting pictures in a non-functional way. They look good on a social media platform where we have no idea if they actually work in the mouth.
Mm-hmm.
So because it's a false image, and our people who get exposed to that believe this is beautiful and this is the norm, and then they end up eventually with consequences after. And our kids get exposed to this world that is a lot of false images and false exposure. So I'm scared for this, including my own children, that they think this is what they see is real. And we know, our generation, had no phone, maybe not your generation, but I had no phone.
Mm-hmm. I had no phone as a child.
Yeah, so we know that a real world looks differently. We need to know how to look into a woman's eyes. We know how to communicate. What we see is quite terrifying, but we shouldn't use that to our financial benefit. If you do dentistry in that way, try to do it in the best way you can, but you need to consider everything we talked about.
Mm-hmm.
Then, fair enough. But I think education, you should never start educating yourself and grow as a person and everything. And do shortcuts. Because what I've seen a lot in London is it's short-term gain, long-term loss. So that's why for me that's a loss. Mm-hmm. Like, try to do what's right, what feels right. Otherwise, long-term you will not be fulfilled with happiness, because you get a backlash. And that's what I experience as well. And I don't want in my life. I want connection, I want love, I want appreciation, and integrity. There are things I want in my life, and you the core pillars in your life to find out who that is. But you have to be you get deceived a lot on all of these images, what is out there. And reality is sometimes very different to what is perceived on social media.
Most frequently, I would say.
Right? And so this is, for me, not the future. And sometimes the people who are good, you don't actually see them. So,
very true. Very true. Well, Stefan, thank you so much for bringing attention to this vital topic.
Thank you for having me.
Yeah, I hope to see lots more people doing lots more screening in our profession.
Me too.
For this big problem. Thanks again.
Thank you, Simon.
So thanks for making it all the way to the end, guys. I hope this episode really gave you a lot of value. If you did enjoy it, then please do share it with your colleagues and hit the subscribe button and like below to help us get bigger guests, bigger value, and really help build this community.